In this video, we're going to look at integration of nervous system function. Sensation. Senses. It's the means by which the brain receives information about environment and body. Now we have general senses and special senses. General senses are distributed over a large part of the body, and they can be divided up into somatic and visceral. Soma means body, so somatic we have touch, pressure, temperature, proprioception, pain, and vibration. Visceral refers to internal organs and consists mostly of pain and pressure. Now, special senses are going to be the sense of smell, taste, sight, hearing, and balance. And sensation or perception is the conscious awareness of stimuli received by sensory receptors. The types of sensory receptors. We have mechanoreceptors, and they respond to mechanical stimulation such as compression, bending, and stretching of cells. And then we have chemoreceptors, which detect smell and taste. And then thermoreceptors detect temperature, photoreceptors detect light, and nociceptors detect pain. And then we have exteroceptors and interoceptors, or visceroceptors. The exteroceptors are associated with the skin, and those are receptors that monitor the external environment. The visceroceptors are associated with organs. And then we have proprioceptors. And these are associated with joints and tendons, and these let your brain know where your limbs are, for instance, in space. So in other words, you can close your eyes and still touch your nose without looking because of proprioceptors. The reason you don't have to look down when you walk is because of proprioceptors. If you want to comb your hair or brush your teeth, again, you can do that without looking because of these proprioceptors in the joints. And then we have sensory nerve endings. And I'm just going to go to the picture for a second here. And what we have here are free nerve endings, which respond to painful stimuli, temperature, itch, joint movement, or proprioception. And one thing that's, well, let's see. Oh, it does mention pain. Okay. And then we have the Merkel's discs, which detect light touch and superficial pressure. Notice how these are right up in the epidermis. Then we have hair follicle receptors that detect light touch. So when the hair bends, you can tell that there's something there touching. If you've ever had like a little bug or something crawling and they bend the hair, you kind of automatically swat or scratch or itch or smack or whatever you do because you're feeling something by that hair moving. Now with other critters, especially those that live in dark tunnels, for instance, where there is no light, they actually rely heavily on that particular type of sensation. Then we have Meissner's corpuscles, and this is for two-point discrimination. And I'll show you what that is in just a moment. But you can see here you have two receptors, and so that allows for two-point discrimination. Now these receptors will be at varying widths. And so if we have areas of less sensation, like a shoulder, for instance, these will be very wide apart. If we have very fine sensation like we do in the fingertips, these are going to be very close. And just to show you a way to measure that, here's a caliper, which you typically use to measure like an EKG with. You would with your patient, and first of all, I would not do the tongue thing with my patient, but that's just for demonstration. But with a patient who you suspect might have some peripheral nerve damage, you can take these, separate them pretty wide, and ask the person, does it feel like I'm touching you with two things or one thing? And if they say two, then you bring it in a little closer. Test again. If it still feels like two, you bring it in again until it feels like you're just touching with one thing. And then you would measure that distance. In the shoulder, like I said, there's not a lot of sensation there. And so we're at about 64 millimeters before it feels like you're touching with one thing, one point. The fingertips, like I said, are very very precise, and so and have a lot of sensation, sensory receptors in the fingertips. So we're down to 4 millimeters where it finally feels like you're touching it with just one thing, and the tongue even more so. We're down to 2 millimeters. Okay, so that's Meissner's corpuscles for 2-point discrimination. Then we have Ruffini's end organ, and that's for continuous pressure or touch. And then finally, the Pacinian corpuscle, also known as a lamellated corpuscle. When you take a piece of paper, put it between two pieces of plastic, and run it through this little heater thing. What is that called? Laminating. And you can see here how we have layers that are laminated together, except we don't call it laminated, we call it lamellated. And so this Pacinian corpuscle is going to detect deep pressure, vibration, and proprioception. And then next we have muscle spindles, or muscle spindle fibers. And these are for proprioception as to muscle stretch and control of muscle tone. So this is what basically sets tone of muscle. And if it gets overstretched, what it'll do is contract down and then relax back out again. Now, the Golgi tendon organ is important in muscle contraction and tendon stretch proprioception. If you overstretch or put a quick stretch in the Golgi tendon organ, it will send information to the muscle to contract. And so when we take your reflexes and we take that hammer and hit the tendon, and the leg kicks out, that's because the tendon thinks it's being overstretched because you're putting a quick little stretch into it. And when that happens, it sends a signal to the muscles to contract to try to protect that tendon. And so here we can see the muscle spindle fiber. And it's going to have motor and sensory fibers that go along with it. And here we can see the nerve fibers going to the Golgi tendon apparatus. Again, we put a quick stretch in here. It's going to cause this muscle to contract, and that's why whatever reflex we're testing, that muscle will contract. The best example is the patellar tendon. We tap the tendon below the patella, and the leg kicks out. Golgi tendon, the muscle spindle fiber, a little more complex, and again, it'll cause the muscle to contract, and then relax back out again until it's the proper tone. And the responses for sensory receptors. The receptor is the interaction of stimulus with sensory receptor, and it produces a local potential. In other words, action potential, a nerve impulse. So we can have primary and secondary. The primary have axons that conduct action potentials, again, nerve impulses, in response to receptor potential. And then secondary have no axons, and receptor potentials are produced, do not result in action potentials, but cause the release of a neurotransmitter. And then we have accommodation or adaptation, and this is decreased sensitivity to a continued stimulus. Good example would be like the sense of smell. If you're, for instance, maybe cooking, that's a good example. And, you can kind of smell what you're cooking or what have you. And maybe you step outside and, we have an herb garden. And so we would go outside and clip our herbs, come back in. And then hopefully your thought is, that smells really good. Okay, you might not notice that because while you're inside, you get used to that smell. If you have a pet, a lot of times you get used to that smell, and visitors might notice it, or you might notice it after you've stepped outside for a while and come back in. Another thing is taste. After chewing food for so long, the taste begins to go away. Plus the fact you're draining all the good stuff out of it anyway while you're chewing it up. But the point is you become adapted. Another example would be like clothing. You don't sit there unless the clothing is like over tight and uncomfortable. But typically we don't pay attention to the feeling of like your socks or your shoes, on your feet, or your, pants, for instance, against your legs or what have you, because we become adapted to the sensation. Now, proprioceptors, as I said before, that tells you where your joints are in space. And we have tonic and phasic proprioceptors. Tonic is an example is you know where your little finger is without looking. Phasic is to know where your hand is as it moves. Okay, so like touching your finger to your nose, tonic, you know where your finger is. As you start to move it, that's phasic, and you know where it's moving to as it then touches your nose. Now in the spinal cord, we're going to have these specific sensory and motor nerve tracts. Let's take a look at these sensory nerve tracts. They transmit action potentials from the periphery to the brain. And each pathway is involved with specific modalities. And the first half of the word indicates the origin, the second half indicates termination. For instance, anterior spinocerebellar. Where does this nerve start? Well, it starts in the spinal cord, and it ends where? In the cerebellum. How about this one? The anterior spinothalamic starts in the spinal cord, ends in the thalamus. Okay, so hopefully you have the idea there. So looking at the spinothalamic system, this conveys cutaneous sensory information to the brain. It's unable to localize the source of the stimulus. The divisions are lateral for pain and temperature, anterior for light touch, pressure, tickle, and itch, and the effective sensation is accompanied by a compulsion to act. So for instance, if you feel an itch, that compulsion is to scratch. If somebody is tickling you, the compulsion might be to smack them. Okay, so you've got the idea there. And if you remember that typically the sensation on the one side of the body actually goes to the opposite side of the brain. So sensation on the left side of the body, it has to make its way to the right side of the brain. And in this case, we can see where we have our nerve endings in our primary neuron as it goes into the spinal cord. And since it's sensory, it's going into the posterior portion of the spinal cord. There's an interneuron where it crosses over and connects, with neurons as it goes through the gray and white commissure here, crosses over and begins its way up. And again, this is spinothalamic. So we're going to start in the spine, work our way up, and terminate in the thalamus. And then from the thalamus, we have a tertiary neuron that goes to the sensory cortex of the brain. Then we have what's called our DCML, or our dorsal column medial lemniscus. And this carries sensation of two-point discrimination, conscious proprioception, pressure, and vibration. And the tracts are the fasciculus gracilis and the fasciculus cuneatus. And here you can see, for instance, a Pacinian corpuscle. And we have our primary neuron. It goes into the spinal cord. Now, this is interesting. It stays in the spinal cord until it gets up to this area around the medulla. And here's where we have the new connection. And you can see the nucleus gracilis here and the nucleus cuneatus. I'm sorry, that's the nucleus cuneatus. And it comes over and it hooks up with the secondary neuron, which is the medial lemniscus. And it works its way up through, again, the medulla, the pons, the midbrain, and then eventually connects to the thalamus. And again, a tertiary neuron is going to go to the sensory cortex, the somatic sensory cortex. And again, this is in the opposite side of the brain. Now, the ones that cross over, we would say these are contralateral, whereas if it stays on the same side, such as this, we'd say these tracts are ipsilateral. Okay, so the tracts that cross over are contralateral. The tracts that stay on the same side are ipsilateral. So this one is the spinocerebellar. So we know it's going to end at the cerebellum. It's going to carry unconscious proprioceptive information to the cerebellum. And the actual movements can be monitored and compared to cerebral information representing intended movement. And the tracts are posterior and anterior. So let's go back for a second. This one is conscious proprioception. Conscious proprioception, okay, I want to touch my forehead. I reach up, I touch my forehead. Unconscious proprioception would be, for instance, like walking. You don't have to think about putting, one foot in front of the other. Instead, you just do it without thinking. You do it automatically. That would be unconscious proprioception. Looking at sensory areas of the cerebral cortex, again, here's our central sulcus. Here's our precentral gyrus, and that's our primary motor region. Here's the postcentral gyrus. That's our primary sensory cortex. In the back, we have our visual cortex and our visual association area. And here I did mention the somatic sensory association area, along with the premotor cortex or premotor area. In the front, we have our prefrontal area. Now this little V shape here in the premotor area, this is called Broca's area. Now Broca's area is for motor speech. It's found on the left side of the brain, so it's in the left hemisphere. Also in the left hemisphere is the sensory speech area, which is Wernicke's area. This is kind of the speech understanding area. So for instance, if someone has a cerebral vascular accident, a stroke, well, and it affects Broca's area, what will happen? Well, that patient will not be able to vocalize. And if you've ever known someone that's had a stroke and they can't talk, very frustrating, because they know what they want to say, but they can't form the words. And that's because, well, Broca's is broke. Okay. Now, with Wernicke's area, they can speak fluently, but nothing makes any sense. And there's an excellent video on YouTube about that. So you might want to search YouTube about a case of damage to Wernicke's area and just listen to the person talk. They're saying perfect words, and you would swear what they're saying makes sense, but it doesn't at all. And so also in this area, temporal lobe, we have the primary auditory cortex and the auditory association area. So that's where your sense of hearing is. I didn't mention the prefrontal area. This is basically your personality. Now looking at pain, the types of pain are referred pain, and this is sensation in one region of the body that is not the source of the stimulus. Phantom pain occurs in people who've had appendages amputated or a structure removed, such as a tooth, and you still feel that limb, you still feel that tooth. And it's very frustrating because you might have an itch, and you know what it feels like to not be able to scratch that itch. Well, if that limb is not there, then that is a very annoying, frustrating feeling. Same thing with pain. When there is a lot of pain going on and that particular limb is not there, what do you do about it? Okay, so it's a very tough thing to treat and deal with. And then we have chronic pain, and that's not a response to immediate or direct tissue injury. Now, here's the thing. The fibers, the nerve fibers that convey information of acute pain or sharp pain to the brain are fairly large fibers, okay? Because the larger the fiber, the less resistance that you would have. Like, for instance, if you had a water hose, you had a very small water hose and a very large water hose, you would have less back pressure, less resistance going through that larger hose than you would through the smaller hose. Same thing with electrical cords. I do some welding, and my extension cord for my welder is a very thick, fat extension cord, whereas, extension cord I have for a lamp is just a very thin cord. And that's because the smaller the wire, the more resistance there is trying to get through that wire, and the more that wire would heat up and possibly cause a fire. Well, pretty much the same thing with the neurons. The larger diameter neurons are much faster and allow that information to get to the brain much quicker, whereas the chronic pain neurons are smaller, and it takes a little longer for that dull, achy pain to show up. And that's why we can use something like a TENS unit. And that stands for transcutaneous electrical nerve stimulation. So it's TENS. Again, transcutaneous electrical nerve stimulation. And that's going to ride along those faster fibers. And so it kind of short circuits the chronic pain. And that's how that little electric stim works. If we short circuit the pain, you don't notice it. And because you're noticing that electric sensation. It would be like if you came to me and said, "Oh, I've got this dull, achy headache." And I said, "You know what? I can take care of that." And I stomp on your foot real hard. I bet you don't notice your headache anymore, right? Because that pain is going from the foot, up to the brain and short-circuiting and going around, bypassing that chronic pain. Now, later on, you're going to have a sore foot and a headache, but what can I do? And so let's take a look at this picture here. And so, for instance, liver and gallbladder, even though your liver and gallbladder is down here, and you will get some pain in that area, you can also wind up with shoulder pain as well. Heart. In males, a lot of times, if you're having heart issues, that pain will travel down the left arm. Now, I say that's more typical in males. In females, it can be a little scarier because the symptoms don't follow what we normally think of as heart pain. Also, up in the left chest area, we can have referred pain from the esophagus. Stomach, well, that's about where the stomach is. Colon's about where the colon is. Now, kidneys, a lot of times, you can, in here, ureter, you can feel it down in the thigh. Like if someone is passing a small stone, sometimes they'll have pain running through the groin area and down the thigh. Okay. And then the appendix, oftentimes, even though the appendix is down in this area, you will feel it closer to the navel area. So again, this is an example of referred pain. The pain is not necessarily where the organ is. And this has to do with fetal development. Because as the fetus is developing, yes, those nerves are right at the organ. But as you grow, those nerves tend to stretch. And so that's why it feels like, the pain is in a different area than where it's actually coming from. And again, that just has to do with those nerves being kind of stretched as you grow. Now, here's the somatic sensory cortex. Remember earlier, in the previous video, we saw what was called the motor homunculus. Homunculus, little man. Well, here is the sensory homunculus. And it looks very similar to that motor homunculus. Okay, and this just maps out the sensory areas. Here's that motor homunculus again that we saw earlier. Again, very similar. So where there is a lot of sensation, you're going to take up a lot more of that hard drive space. And again, where there's finer motor movements, again, you're going to take up a lot more hard drive space in the motor cortex. And here's just another one showing the motor cortex. And now looking at the descending spinal pathways, we're going to have both direct and indirect descending spinal pathways. Descending means we're going to start off at the cortex, in this case the motor cortex, and from here our upper motor neurons are going to pass from, again, the precentral gyrus, which is the primary motor part of the cortex. The precentral gyrus is going to go through the internal capsule. Again, those upper motor neurons will go through the cerebral peduncles, then through the pons, and then when we get to the medulla, some of these fibers are going to cross over at the pyramidal decussation, and others are going to continue down on the same side through the anterior corticospinal tract. And when they reach their level of the spinal cord where they need to cross over, they'll cross over from there. Okay. Now at the pyramidal decussation, as they cross over, they're going to continue down through the lateral corticospinal tract. Okay. There they're going to hook up with an interneuron, where they're then going to, that interneuron's going to hook up with then the lower motor neurons, which will exit the anterior portion of the spinal cord and go on to their target organ, in this case, the neuromuscular junction, in order to control that particular muscle or muscle group. Now, the indirect pathway, we just looked at the direct, but the indirect pathway is they synapse in some intermediate nucleus rather than directly with lower motor neurons. Those tracts are going to be the rubrospinal, the vestibulospinal, and the reticulospinal. So again, we start off at the motor cortex, and you can see that we're going to have fibers that are going to synapse in the lentiform nucleus. Also, we have some going through the not quite the internal capsule. And now looking at indirect descending spinal pathways, they're going to synapse in some intermediate nucleus rather than directly with lower motor neurons. And if we look up here, we can see the starting point again in the motor cortex. And one of those synapses are going to be in the thalamus and the lentiform nucleus. From here, we have fibers that are going to come down to the midbrain, and they're going to cross over in from the red nucleus. And then also we're going to have some fibers that are going to come through the substantia nigra. So again, this is our crossover point to the opposite side, going through the pons, the medulla, and then finally to the rubrospinal tract and reticulospinal tracts, where it then exits at the anterior spinal cord and going to its target muscles. Now, speech, as I mentioned before, speech area is normally in the left cerebral cortex. We have the Wernicke's area for sensory speech and Broca's area for motor speech. And as I said before, it's a good idea to go to YouTube and look at examples of each of these. Now, aphasia is absent or defective speech or language comprehension. Brainwaves. Brainwaves, we have the electroencephalograph, or EEG, and that's the brain's electrical activity that we then record. And the brainwave patterns, we have alpha, which is the resting state with eyes closed. We have beta, which is during intense mental activity. And theta occurs in children, but also in adults experiencing frustration or brain disorders. And then delta occurs in deep sleep, infancy, and severe brain disorders. Memory. We have sensory memory, which is very short-term retention of sensory input. Short-term memory is information is retained for a few seconds to minutes. Long-term memory is explicit or declarative, and we have a retention of facts, and it's accessed by the hippocampus and the amygdala, the emotional brain. And then we have implicit or procedural, such as development of skills as riding the bike. Okay, I want to go back over these one more time here, and let's look at this. Okay, sensory memory, most is lost immediately. That's why if you're trying to learn something, the first time you hear it or see it, you're going to forget most of it. Okay, you've heard that term in one ear and out the other. That's pretty much sensory memory. Most is lost immediately. Short-term memory, most is lost within a short time as new information is received or if the person is distracted. Okay, so that's short-term memory. Now, how do we get to this long-term memory? And that's important, you know, with you going into maybe healthcare, for instance, if you're taking this class. Well, one way is explicit, and here much is lost through time, but one way to really get it to stick is like I like to try to tell stories, and I think I do that more in person, I guess, than I have been on these videos here, but I have made some videos that were kind of funny. And so you want to kind of make up stories about some of this stuff and make it funny or exaggerated or shocking. That's why some of the mnemonics, especially the ones I can't repeat in these videos, are kind of shocking because you're going to remember them. Now, if I asked you what you had for lunch 4 weeks ago, you know, you probably wouldn't remember unless you eat the same thing every day. But most of the time you wouldn't remember. But if you were sitting there eating and all of a sudden a car comes crashing through the window and just misses your table, you're going to remember everything about that because it's going to be kind of wired into your emotional brain. Okay? So when you're trying to learn something, make it outrageous, make it funny, make it shocking, put a story together with it. Okay. If it's dry, you're not going to remember. And then implicit or procedural, it says a small amount is lost through time. And again, an example would be like a skill such as riding a bike. Now we talk about muscle memory. Your muscles do not have memory. What has memory is your brain. And so this implicit or procedural memory is actually what we would call muscle memory. So the brain is remembering how much to contract that muscle, you know, and which way to turn and what have you, depending on what that activity is. And that comes with repetition. General CNS disorders. You can have infections such as encephalitis. That's an inflammation of the brain. And sometimes mosquitoes will carry viruses that can cause encephalitis. And then rabies, which is a viral disease transmitted by the bite of an infected animal. And then multiple sclerosis, or MS, possibly involves autoimmune response to viral infection. Other disorders, we have stroke, a CVA, or cerebral vascular accident, which is caused by hemorrhage, thrombosis, or embolism. So really there's two types of strokes. There's what we call hemorrhagic, which means that a blood vessel has burst and the brain is now bleeding. And then we have ischemic strokes. And that's where we're blocking off blood supply to the tissue, and that's where the thrombosis or embolism comes in. A thrombosis is a stationary blood clot, whereas an embolism is a blood clot that's moving. And then we can have an aneurysm, and this is a dilatation or ballooning of an artery. If you get a ballooning of the artery in the brain, it can compress on a nerve. If that aneurysm bursts, now you have a hemorrhagic stroke. And then Alzheimer's disease is a very severe type of dementia. There's a lot of research going on as to what actually causes it and how to treat it. And so that's an ongoing thing. Won't mention a whole lot about it. Most everybody has heard of it. And like I said, whatever I would say about it here will change possibly by the time you see this video. And it's good to look up the latest research. And then epilepsy is a group of brain disorders where there are seizures, basically electrical storms in the brain. And the effects of aging on the nervous system, you have a gradual decline in sensory motor function, reflexes slow, and the size and weight of the brain decreases. And so you have decreased short-term memory in most people, but long-term memory remains unaffected or improved.